All right, welcome everyone. Today we are diving deep, and I mean really deep, into the science of avian influenza, specifically the H5N1 subtype. We're going to break down the virus, how it moves, and the impact it has, all based on the hard data and the scientific findings. Let's get right into it.
So here's our game plan. We've broken this down into 5 key parts. We'll kick things off with the virus itself, then we'll look at how it makes that scary jump to humans. After that, we'll cover how doctors identify it, what it actually does to the body, and finally, how we can fight back. It's a straight shot through the science.
Okay, first up, let's really get to know the H5N1 virus on a molecular level. I mean, if we're going to understand the threat, we have to start with the pathogen itself, right?
So, what exactly is this thing? Well, H5N1 is a subtype of influenza A. It primarily hangs out in birds, but here's the kicker. It has this dangerous ability to jump over to mammals, and that includes us. The really crucial part, the thing that keeps scientists up at night, is its knack for mutating super fast.
Okay, this table is where things get really interesting because it shows you exactly why influenza A is such a big deal. You see, types B and C, they only do something called antigenic drift, but influenza A, it can do that and something called antigenic shift. Now, you combine that power up with its massive host range, we're talking birds, humans, even marine mammals, and boom, you've got the perfect recipe for a potential pandemic. Let's break that down a bit more, because this is super important. Think of antigenic drift like the virus is making tiny little typos every time it copies itself. These small changes are exactly why you need a new flu shot every year. But antigenic shift, oh, that's a whole different ballgame. That's a massive, radical change. It's when 2 different flu viruses infect the same cell and literally swap huge chunks of their genetic code. And that can create a totally new virus our immune systems have never ever seen before. That is the pandemic trigger.
You know the H and the N in H5N1? Well, they stand for hemagglutinin and neuraminidase. The easiest way to think about them is as the virus's toolkit for breaking and entering. HA, the hemagglutinin, that's the key that unlocks a host cell, but it's super picky. The avian virus, our H5N1, prefers one type of lock, the alpha-2,3 receptor, which you find deep in the lungs of humans and in the guts of birds. The regular human flu? It likes the alpha-2,6 receptor, which is all over our upper airways. And that little difference is actually a huge reason why H5N1 doesn't spread easily between people right now. Then you've got NA, the neuraminidase. That's the tool that busts the new viruses out of the cell so they can go infect more.
All right, that brings us to our second section, the zoonotic leap. How in the world does a bird virus make that jump across the species barrier and end up in a person?
This timeline really maps it all out. It starts back in '96, first spotted in geese in China. Just 1 year later, boom, the first human cases pop up. By 23, it's a global problem in bird populations. And then you see this 2024 update, finding it in U.S. dairy cattle. That's a really big deal because it shows the virus is still actively expanding its mammal playbook, which definitely makes surveillance efforts even more critical.
So, how is this jump actually happening? The data from the field is crystal clear. Human infections are almost always tied to really close, direct contact with sick birds or their messy environments. We're not talking about just walking past a chicken coop. We're talking about high-risk situations like culling poultry without any protective gear, or in some documented cases, even consuming dishes made with raw, contaminated bird blood.
And this concept is one of the biggest nightmare scenarios for virologists. It's called the mixing vessel hypothesis. See, pigs are biologically unique. Their respiratory tracts have both the bird flu-friendly receptors and the human flu-friendly receptors. So what does that mean? It means a pig can get infected with a bird flu and a human flu at the exact same time. Inside that pig's cells, the 2 viruses can mix and match their genes. And the fear is that they could create a brand new hybrid virus that has the deadly punch of H5N1 but spreads as easily as our seasonal flu.
Okay, Section 3. How do doctors and health officials actually identify an infection? How do they go from someone feeling sick to a confirmed case of H5N1? Well, it's a very careful, structured process.
So they use this step-by-step system. Step 1 is a suspect case. That means you have the right symptoms, like a fever and respiratory issues, plus a history of exposure. You were around sick birds. Then you can get upgraded to a probable case. That happens if a preliminary test comes back positive for any influenza A or if the person's condition gets really severe. But and this is key, the final confirmed case label only gets stamped on after a highly specific lab test, a PCR test, comes back positive for the H5N1 subtype. This whole process is designed to be super accurate and to avoid any false alarms.
All right, on to Section 4, the clinical impact. What happens when someone is a confirmed case? What is this virus actually doing inside the human body? And frankly, the data paints a pretty grim picture of a disease that hits hard and fast.
The virus's main target is the lungs. That's what leads to severe pneumonia and, quite often, something called acute respiratory distress syndrome, or ARDS. And unlike your typical seasonal flu, a lot of patients also get intense gastrointestinal symptoms: nausea, vomiting, diarrhea. Lab work almost always shows a big drop in key immune cells and platelets. But the scariest part is the speed. We're talking an incredibly rapid clinical course, with some data showing 68% of patients developing ARDS in under a week.
And this image right here gives you a visceral look at that lung damage. These are CT scans. See all those hazy, fuzzy areas? Doctors call those ground glass opacities. And that's basically where the air sacs are starting to fill up with fluid. Then you have the really dense white patches, the consolidation. Those are parts of the lung that are just completely flooded with fluid and inflammatory cells. They can't do their job of exchanging oxygen anymore. And look how fast it spreads across the lung fields in just a matter of days. It's devastating.
Now, if we were to zoom in with a microscope, this quote from a pathology report tells the same brutal story. Diffuse alveolar damage. That means widespread destruction of the tiny air sacs where you breathe. Interstitial fibrosis. That's scarring. Infiltration of leukomonocyte and plasma cells. That's the body flooding the area with inflammatory cells. It's basically a picture of the immune system launching an all-out but ultimately self-destructive war inside the lungs.
So what's the end result of this incredibly rapid and severe attack? Well, it's a tragically high case fatality rate. Looking at all the confirmed cases that have been tracked since 2003, 59% of them have been fatal. It's a sobering number, and it really underscores why H5N1 is taken so seriously by public health officials, even though the number of human cases has been relatively small so far.
Okay, this brings us to our final and fifth section, medical intervention. When a patient is this sick, how do clinicians fight back? Let's look at the data from the front lines.
For the absolute most critical patients with ARDS, doctors sometimes turn to a machine called ECMO. You can think of it as an artificial lung outside the body. It takes the blood out, puts oxygen in, and sends it back. Now this chart shows you what a high-wire act this is. The orange line, that's the patient's blood oxygen. The machine is holding it stable, which is literally life-saving. But now look at the blue line. That's the platelet count. See how it just craters? That's a super common and very dangerous complication. ECMO is a last-ditch effort, a true Hail Mary that balances on a knife's edge.
The main weapons we have to fight the virus directly are antivirals, specifically a class called neuraminidase inhibitors. The two big ones are oseltamivir, you probably know it as Tamiflu, it's a pill, and zanamivir, which is inhaled. They're the go-to drugs. But here's the really important and frankly worrying piece of information on this slide. Look at that bottom row. We've already seen strains of H5N1 that are resistant to oseltamivir. That is a huge red flag for future treatment.
So how patients are managed is all based on a tiered system of severity. Category A is for mild illness. You basically get symptomatic treatment and isolate at home. Category B is for more severe cases or high-risk patients. That's when they bring in the antiviral oseltamivir, but you're still likely at home. But Category C, that's for the really complicated cases. That means immediate hospitalization, antivirals, and all the supportive care they can throw at it, like mechanical ventilation or even ECMO.
You know, just as important as knowing what to do is knowing what not to do. And the World Health Organization is really clear on this for severe influenza. Their guidelines explicitly recommend against using a few treatments. That includes certain types of antivirals and plasma therapy. They're also very cautious about using corticosteroids. While you might think they'd be good for inflammation, the data suggests they might actually do more harm than good unless a patient is in full-blown septic shock.
So there you have it. We've walked through the science of the virus, how it jumps to people, and how doctors fight it. The data is clear. While H5N1 isn't spreading easily between humans right now, its potential to cause severe disease is undeniable. And all of this leaves us with a massive question for the future. As these zoonotic viruses keep evolving, keep testing the boundaries between species, how do we as a global community get better at surveillance and data sharing so we can see the next threat coming and be truly ready to face it?